I'm Dr. Tim Allen Williams, and Chair of Medicine here at University of Louisville, and it's my pleasure to announce my colleague, who I've known for quite a while, Dr. Dinesh Kalra, who will be speaking about new advances in dyslipidemias this morning. Dr. Kalra is currently the Division Chief in Cardiovascular Medicine, and he's my Vice Chair for Quality here at the Department of Medicine. He's a professor and endowed chair of cardiovascular innovations, and he is an expert in everything. So he and I go back a while. We met each other in an elevator in my condo in Chicago. And he talked about, when I was chief of cardiology at Rush, he talked about wanting to go into back to academics. And we had a good conversation and ended up hiring him. And he instantly at Rush University became, I would say, I like to say, master of everything as well as jack of all trades. And he was a good candidate for chief of cardiology, and he took over this program in 2021. And he was actually helpful in my recruitment, so I could come back and we could work together again. And so he has a good track record as a cardiac imager, background with training in a wide variety of cardiovascular specialists. So he's the ultimate guy for to run a cardiovascular division. And we're looking forward to your comments this morning about advances in lipid management for the internist.
Thank you, Dr. Williams, and thanks for that kind introduction. And it genuinely has been a pleasure knowing you for over a decade now. And we're very happy to have you here at University of Louisville. So first of all, Happy New Year, everyone. And I wanted to title this Advances in Lipid Management in 2023, but given that it's only been 5 days into 2023, I thought I would title it Advances in Lipid Management for the Internist and What's Happened over the past few years. And I hope at the end of this, you take away that lipid management has come way beyond statins. And I hope to enthuse you with some of the data that's coming out that looks really fantastic in terms of what we can do for prevention and to reduce cardiovascular risk in our patients. So the first slide is always, when I do these talks, it's always a sobering slide. And if you look at this graph on the left, for the past 5 decades, we've been making good gains in reduction of cardiovascular death, as well as improvement in dyslipidemia. And in fact, the improvement in dyslipidemia accounted for that reduction in cardiovascular mortality. But then if you look at 2010, those gains started to reverse. We started to see an uptick in cardiovascular death again. And this is not just from lipids, but primarily from our aging population, the increase in obesity, increase in diabetes. But it is a klaxon call for alarm because, we did so well for 50 years and now things are starting to go in an opposite direction. And it's not just all about drugs. Prevention includes lifestyle also. So I think we'll have to focus more on lifestyle and over the next century. And I think that's why Dr. Williams' message about improvements in the diet are going to be crucial. Even though most of my talk is going to focus today on drugs and biochemical pathways to reduce atherosclerosis, I don't want all of you to forget that at the heart of all this, prevention includes a healthy diet and exercise. The bar chart on your right shows you that the same phenomenon happened with lipids. Lipids started to get worse compared to 2014. If you look at the red bars in 2016, cholesterol levels were rising in all races and both in men and in women. And of course, as you might expect during COVID, these trends got even worse as people sat at home and didn't get enough exercise. Now, all of you know that there's a very high burden of cardiovascular disease with 25 million Americans having coronary artery disease. Every 40 seconds is another myocardial infarction. There's about 3/4 of a million MIs every year. And of these, 1/3 of people will die, oftentimes before they even reach the hospital because of sudden cardiac death. And overall, there's about 500,000 deaths every year from cardiovascular disease, which accounts for 1 out of every 3 deaths. And in fact, if you look at all the popularity that cancer and other diseases get in terms of NIH dollars as well as publicity, they rank below cardiovascular death as causes of death. CVD still remains the #1 cause of death across the world, accounting for 1 in every 3 deaths. I thought I'd give you a multiple choice question at the beginning of my talk, because a lot of the material I'm going to cover is going to talk about these lipoproteins. So the first and only MCQ I have is, which of the following lipoproteins listed below directly causes atherosclerotic cardiovascular disease? And the choices are high LDL cholesterol, low HDL cholesterol, high triglycerides, high lipoprotein little a, and for those of you who don't know what this is, we'll talk more about this. And lastly, high triglyceride-rich lipoproteins, abbreviated TRLs. And so what this question is getting at is really, what do we need to infer causality as opposed to a mere association? So #1, you need to have epidemiological data and genetic or Mendelian randomization data showing that a biomarker, for example, in this case, LDL, is associated with coronary artery disease. You need biological plausibility that LDL can cause coronary disease. And lastly, you need randomized controlled trial data showing that reducing exposure to this biomarker reduces disease. So of these, a few of them are causally related and the others are not. And so let's talk about which ones are. High LDL cholesterol, triglyceride-rich lipoproteins, and Lp(a) are causal for atherosclerosis. And this may come as a surprise to some of you, but low HDL cholesterol is not causal. It is associated, but it is not causal. Similarly, high triglycerides are not causal. And the effects of low HDL and high triglycerides are mediated via TRLs. And so TRLs are getting a lot of attention, and we'll talk about those in a bit. Now, genetic association has shown us that this is a very large database of 20,000 patients who had myocardial infarctions and about 100,000 patients who did not. And what the investigators did in these large databases, one of them is called Cardiogram. They assessed for the presence of single nucleotide polymorphisms that regulate levels of LDL and HDL in plasma. And so in the myocardial infarction cases, the single nucleotide polymorphisms, also called SNPs, that associated with LDL clearly gave a signal for increased odds ratio of having myocardial infarctions, whereas a low HDL did not. And so these kinds of large databases and analysis of genetic traits that we are born with allows us to carry out these sort of experiments in nature without giving people drugs to see if a particular biomarker carries a high risk of cardiovascular disease. A lot of you, I'm sure, have seen this slide. This comes from the Cholesterol Treatment Trialist Collaboration, which now has data for over 200,000 patients going back about 4 decades who have been treated with statins to lower events. And there's 2 points I want to make on this slide. What you see here in boxes of various trials, the control group and the treatment group. And on the x-axis, you see a reduction in LDL cholesterol that you achieve by giving people statins. Most of these drugs are statins. And on the y-axis, you see a reduction in cardiovascular event rate, also called MACE, or major adverse cardiovascular events. And what you'll notice is, as you reduce the LDL cholesterol, you get a decrement in MACE. And that doesn't matter which trial you look at. The 2 things that came out of this is the more the reduction in LDL, the more you benefit in MACE reduction, such that we've now come up with a formula that allows us to calculate what sort of benefit you see for every milligram per deciliter reduction in LDL, and that's listed here. But for the residents, it's easy to remember that a 1% lower MACE is achieved every time you drive down the LDL cholesterol by 2 milligrams per deciliter. And that holds good, not just for statins, but even for non-statins that lower LDL, such as seen here with the IMPROVE-IT trial, or even with the PCSK9 trials that are listed above, Odyssey trial, etc. Another important concept is, this is again data from Mendelian randomization studies, looking at lower LDL levels. We already talked about lowering it with drugs versus genetically lower LDLs. As most of you may appreciate, we're born with a certain genetic background that varies from individual to individual. Those minor changes in gene function are called SNPs, or single nucleotide polymorphisms. And I'll give you an example here. If you focus your eyes on the right-hand side of the slide, at the top, you'll see PCSK9, RS115, etc. That is a particular single nucleotide polymorphism that leads to about a 15 or 16 milligram per deciliter lower LDL at birth. Just because this is the kind of polymorphism that leads to a slight underperformance in the activity of this enzyme, and you're genetically endowed with this sort of trait. So you're born lucky, your PCSK9 doesn't work as well, and so you naturally have, compared to a general population, about 15 milligrams per deciliter lower LDL cholesterol. And you'll see on the y-axis, these individuals have about a 25% lower risk of cardiovascular disease. Whereas if you take the same degree of LDL reduction that you achieve, for example, in the IMPROVE-IT trial shown in the red at the bottom, you have a much lower reduction in cardiovascular disease. It's only about 6%. And you may ask me, rightfully so, why is that? For the same percentage reduction or milligram per deciliter reduction in LDL, shouldn't you be getting the same cardiovascular disease reduction? Well, no, because there's a difference. Most of the times when we treat patients with drugs, we're starting at age 40 or 50, oftentimes after they've had a myocardial infarction, as was the case in IMPROVE-IT. Whereas when you're genetically endowed with a lower LDL, you have that lower LDL and lower exposure to your arterial circulation of that cholesterol right from birth. So you have many more years of protected endothelium and healthy arteries, and therefore your risk of cardiovascular disease is disproportionately better. So you have much lower risk of cardiovascular disease. And these kinds of large databases and Mendelian randomization studies have really allowed us to study not just what is the role of LDL, HDL, but also triglyceride-rich lipoproteins, as I talked about. This slide illustrates an important concept. These are trials done with statins mostly over the past 2 decades, demonstrating that there is really a good tight relationship between LDL reduction and reduction in MACE. But number 2, there is no floor at which you stop seeing benefits in MACE if you drive the LDL down further. And so you'll see the 4S trial listed up top was done in Scandinavia back in the 1980s. And the LDL at that time in placebo patients who came into Scandinavian hospitals with a myocardial infarction was as high as 188. Remember, this was a time of liberal butter use in Europe and the US, and you don't see these high numbers of LDLs these days. Today, the average US LDL in the population is about 105, 110. So when people in 4S were treated with simvastatin, you brought down the LDL to 111, and you had a 34% reduction in cardiovascular events. Now, if you take this trial at the very bottom of the slide, Odyssey Outcomes, which was a contemporary trial done about 5 years ago, the LDL in the comparator arm, these are people on statins, was only 92. And even then you got a further benefit by driving the LDL down to 40, such that this went to demonstrate that 2, lower is good, and number 1, lower is good, and number 2, there really is no level of LDL below which you stop seeing a benefit. So if somebody comes in with an acute coronary syndrome and you see an LDL of 70, that doesn't mean you don't have to treat that patient, because you do get additional benefit by lowering the LDL even further. Now, this slide is important because there's, despite all of this data, and I talked about these large Mendelian randomization studies and the data from cholesterol treatment trialists, there's still a lot of misinformation out there. I'm sure all of you who are in clinic get pushback from patients saying, I don't want to take a statin. I read on Google that it causes dementia, or it causes my kidneys to fail or my liver to fall out. And there's a lot of fake news out there. And unfortunately, it's not benign, because statin cessation or non-adherence results in a rebound increase in cardiovascular events. So it's important to talk to your patients and show them the data. And so we have data. This is a large analysis looking at safety and efficacy of statins, published in Lancet in 2016. And essentially, it summarizes what the pros and cons are. So if you take 1,000 patients and treat them with a statin for 5 years, for a secondary prevention patient, example, somebody who's had a myocardial infarction in the past, you will prevent an adverse cardiovascular event in 100 out of those 1,000 patients, about 10% benefit over 5 years. In primary prevention, you get a smaller benefit, 50 patients will benefit, because these people have never had an event before, so their baseline risk is lower. And then in terms of harms, these are actually, it's a very favorable benefit ratio. You get 5 to 10 excess cases of diabetes in 1,000 treated patients over 5 years. And most importantly, these people are pre-diabetic to start with. So you don't convert healthy people with an A1C of 4 or 5 into diabetics. The people you push over to get diabetes with statin treatment are those who have borderline A1Cs, are obese, and would be diabetic anyway. And in an analysis of statins, you basically accelerate the onset of clinical diagnosis by about 3 weeks. But remember that diabetics are the highest risk for cardiovascular disease, so they have proportionally more to gain by statins. So you should never withhold a statin in a pre-diabetic or a diabetic just because you think that they will get diabetes. In terms of myositis and rhabdomyolysis, these are really small numbers. Same thing for hemorrhagic stroke. And there's no increase in cancer. In fact, there's a lot of data now showing that there may be a slight decrease in certain forms of cancer, no increase in dementia or kidney disease. So I find this slide really helpful to share with my patients when they tell me that statins are giving them lots of issues. Another concept to understand, and this is really puts things in perspective, is that even though the average US LDL today is 105, remember that that's not the LDL in a lot of mammals, and that's not the LDL that we're born with. We're born with an LDL of about 30, and then it starts to rise up slowly. And by the time we're into adulthood, it gets up to 105. And that's because of our Western lifestyle and industrialization. If you look at hunter-gatherer communities across the world, people in the Amazon who live in jungles, they have an LDL of about 35. And so for the people who make the argument that you need certain amounts of cholesterol for you to be able to function, the pushback we give them is, well, when is cholesterol more important, if not important in a neonate or an infant whose brain development is very rapid? And they do just fine with a serum cholesterol of 30, 35. And so there's really no reason to have the cholesterol we see today, and we don't think 105 is healthy. Now, we're going to talk a lot about statins, but I do want to point out that statins have multiple benefits aside from lowering LDL cholesterol. And these pleiotropic benefits extend to what they do to the arterial wall and the plaque in the coronaries. So this is called passivation of plaque, in which they increase this fibrous cap, and that increase in the fibrous cap protects the plaque from rupturing and causing thrombosis and a myocardial infarction. So this increase in what we call thin cap fibrous atheroma is an important effect of statins. They decrease the lipid core. So this delipidation is also an important component of them. And they increase calcification and stabilize plaque. They reduce inflammation, and you can study most of these changes either with intravascular ultrasound or catheters in the coronaries with a technique called near infrared spectroscopy, or by coronary CT angiography, where you can characterize plaque. Now, the 2008 guidelines were evidence-based for the treatment of cholesterol, and they correctly gave primacy to statins given the wealth of data that we have with safety and efficacy. So that forms the underpinning of treating patients with cholesterol who are at risk, high cholesterol who are at risk. Now, you would think that given all of that data, we would be doing amazingly well in terms of prescribing statins and uptitrating them. Unfortunately, that's not the case. This is a recent analysis from 2021 in 5,000 patients with cardiovascular disease. And if you look at the number of people in this Gould registry who got any statin, there were a lot of people who got a statin. 2 out of 3 people, 1 out of 3 people got to goal. So 67% had an LDL more than 70. We want the LDL less than 70 for secondary prevention patients. And in terms of physician inertia, only about 1 out of every 5 patients had any intensification of lipid-lowering therapy after 2 years. So it's not just, the drugs are not as potent. So we'll talk about how statins alone are not sufficient, but aside from that, we as physicians and patients are not getting to goal, and we as physicians are not intensifying or adding medications as often as we should be. So there's many reasons patients don't get to goal. Obviously, an important one is that many of them stop therapy, they don't adhere for various reasons. Some of those I've shared with you, the misinformation that's there. They may start off with very high baseline levels of LDL, and we'll have a case that will show you that. Some of them genuinely get side effects, especially myalgias, but that's often overestimated by both the patient and the physician. And if we have time, we'll discuss that. False concerns about diabetes. And of course, then some patients, because of their genetic makeup, may not respond as well to statin therapy. But at the end of the day, 7 out of 10 patients are not getting to goal, as I shared with you. So there's a need to add on additional therapy. And fortunately, these days we have additional therapy. The first step you should always do is, try to increase the dose of the statin. But remember that when you double the dose of the statin, you don't get a doubling of the LDL lowering. You get only an additional 6% reduction in LDL. So if you start somebody on 20 of atorvastatin, then you go up to 40 and 80, you will only get an additional 6% reduction in LDL every time you go up, double the dose. What all of this means is, despite everything we've done over the past 4 decades in terms of treating patients with statins and other lipid-lowering drugs and blood pressure medications, we still have a ways to go. Shown in the green here is the residual risk. So despite treatment, 60 to 70% of risk remains untreated. And that's why we see people back in the hospital all the time with recurrent events. Now, this is a busy slide, but luckily, we do have other options outside of statins. And I just wanted to share with you the mechanistic pathways that scientists have looked at to try to lower LDL cholesterol further. We'll start with the center of the slide, where statins reduce LDL cholesterol by blocking HMG-CoA reductase. This is an enzyme that's a rate-limiting step in cholesterol synthesis. There's a new drug, which is FDA approved, called bempedoic acid, which acts one step upstream of this HMG-CoA reductase on an enzyme called ATP citrate lyase, and that also reduces cholesterol. Now, most of these other drugs you may not have heard of. They're used only in specialty clinics such as ours. Mipomersen was available. It has now been withdrawn. It's an ApoB100 mRNA antisense oligonucleotide. And you'll hear a lot about RNA therapeutics. And they are really amazing drugs because they selectively act on their target to prevent translation of the protein. And that can be very powerful in terms of LDL reduction. All of you have heard about PCSK9 inhibitors. PCSK9 stands for proprotein convertase subtilisin kexin type 9. You don't have to memorize that name, but essentially just remember that PCSK9 is the bad guy. And having high levels of PCSK9 means you have high levels of LDL. So we try to reduce PCSK9 activity. In these cases, you can do it by using injectable monoclonal antibodies, which are commercially available. Or there's progress going on now with an oral peptide, a compound made by Merck that is in early phase trials. There's even vaccines. Another way of reducing PCSK9 activity is to use a small interfering RNA with a drug called inclisiran, which is also FDA approved. This prevents the translation of the messenger RNA into the protein. And so if you don't have PCSK9 protein, you're basically blocking the bad effects of PCSK9. You'll see certain other drugs listed here. ANGPTL3s, angiopoietin-like 3. This is another important mediator of high cholesterol. It does so by blocking the activity of this enzyme called lipoprotein lipase. Lipoprotein lipase is important in converting VLDL to IDL and LDL and hydrolyzing triglycerides. So having high levels of ANGPTL3 means you have higher levels of LDL. So there's a monoclonal antibody now called evinacumab, which can be used to block ANGPTL3. And at the moment, it's approved only for homozygous hypercholesterolemia, but there's trials underway for heterozygous hypercholesterolemia and for patients with coronary artery disease. Another compound that is in development is called olezarsen, and this is an antisense oligonucleotide that blocks an like apoprotein called apoprotein C3. Apoprotein C3 is again an important regulator of LPL. It blocks lipoprotein lipase. So again, you want to inhibit apoprotein C3 to try to make LPL work better so that you can lower the cholesterol. So lots of different pathways and mechanisms and drugs, and within the drugs, there's antibodies or RNA therapeutics that work in concert to try to lower LDL and triglyceride-rich lipoproteins via different mechanisms. On the right-hand side of the slide, you know about this drug, ezetimibe, which blocks intestinal absorption of cholesterol. Lomitopide is available for, it's used rarely these days for patients with homozygous hypercholesterolemia. It blocks an enzyme called microsomal transfer protein. We don't often use bile acid sequestrants these days to block intestinal absorption of cholesterol. And we'll talk a little bit more about this compound called CTEP, which is cholesterol ester transfer protein. And for a long time, we focused our efforts on CTEP inhibitors because they used to raise HDL. And we thought incorrectly that raising serum levels of HDL would prevent cardiovascular disease. Well, it turned out that was not true. Those drugs did not work. But we still have a couple of drugs that not only raise HDL by blocking CTEP, but also decrease the LDL. And so you might hear about this drug in clinical trials called obicetrapib, which is potentially going to reduce cardiovascular disease. We've been involved in the clinical trials for most of these drugs. And so if you have patients who are difficult to treat, we always have ongoing trials, for example, with this compound, obicetrapib, or other compounds listed here that your patients may qualify for. Now, I briefly want to talk about there are drugs that improve cardiovascular outcomes, and there are drugs that did not improve cardiovascular outcomes, as you heard about. For example, the CETP inhibitors, such as torcetrapib, et cetera, did not improve cardiovascular outcomes. So even though we may improve a biomarker, it doesn't translate into cardiovascular improvement. Another big surprise was niacin, which did not improve cardiovascular outcomes. In fact, it may increase the risk of stroke a little bit. So when I see patients in clinics who are on these older drugs that don't work well or actually may cause harm, I stop them. And in fact, there's a billion-dollar industry that has for a long time focused on fenofibrate, which had zero cardiovascular outcomes data. It did reduce triglycerides, but in terms of cardiovascular prevention, it is not panned out. Which drugs do improve outcomes? We know about statins. Ezetimibe does improve outcomes. Obviously, the PCSK9 inhibitors, I'll show you data on that. I'll show you data on fatty acids, icosapent ethyl. Bempedoic acid actually just last month reported positive outcomes. And then we talked about the CETP inhibitors. They improve outcomes not by increasing the HDL, but by lowering LDL. So anisotropic was published a few years ago in New England. It did improve cardiovascular outcomes, but its LDL lowering was weak. This new drug that we're doing in clinical trials lowers LDL by about 40–50%. And it's hoped that this will show a massive improvement in outcomes. Now, there's also another blocker of Lp(a) called pelacarsen, which is in clinical trials. It's supposed to report next year, and it'll be very interesting to see if these kinds of agents also improve outcomes. PCSK9 inhibitors, you know about this. PCSK9 is a receptor on the cell surface. And it's a bad guy, like I said, because it destroys the LDL receptor. The LDL receptor is important to bind LDL from the circulation, internalize it, and metabolize it. If you destroy the LDL receptor, LDL cannot be taken into the hepatocyte, and that's what PCSK9 does. So if you want to lower LDL, what you'll do is you'll block the PCSK9, thereby increasing the number of LDL receptors on the hepatocyte, and that will reduce LDL cholesterol. There were 2 drugs in clinical trials that are commercially available, studied for PCSK9 inhibitors. These are monoclonal antibodies, very large trials. This is what cardiovascular outcomes trials generally look like, 20–30,000 patients. These are patients with established cardiovascular disease and LDL more than 70 who were randomized to evinacumab. The trade name is Repatha for those of you who have used it. This was published in New England Journal in 2017. And the primary endpoint was cardiovascular events. The drug on top of a statin, the placebo arm is not genuine placebo. It's everybody's getting a statin. It would be unethical to not give patients with atherosclerotic cardiovascular disease a statin. So placebo is statin, red is evinacumab plus statin. You had a 56 milligram per deciliter reduction in LDL, about a 59% reduction in LDL. So low numbers in these trials. The treatment LDL was only 26. And you had a reduction in cardiovascular events with a relative reduction of 15–20% in cardiovascular death, MI, stroke. Similar trial in the ACS population. So these are post-ACS patients, again, large trial, 18,000 patients randomized to alirocumab, which is Praluent, published in New England Journal in 2018, versus placebo. And you'll see at 3 to 4 years, you get an absolute risk reduction of 1.6% in cardiovascular events, relative risk reduction of about 15%. So these have made it into clinical use, and they've actually transformed the landscape of trying to get people to goal. So before this in statins, you would get about 30% of patients to goal. With the addition of these drugs, you get 80–90% to goal being defined as less than 70. So I often get asked this question by patients and physicians: is there an LDL level that's too low? Well, we know from, again, genetic data that there are individuals with a loss of function mutation in PCSK9, just as an example, who are very low LDLs because they're genetically born with a low LDL and they're healthy. as low as 15 milligram per deciliter. There have been case reports of these women having babies, living normal lives. Obviously, they're not demented or they don't have renal failure, etc. So all of those things are important. We have now in nature an experiment with very low LDL, and these folks are healthy. And number two, the drugs that we have used now have about 8 years of data available, and very low LDL levels in the range of 5 to 25 are not associated with any increase in adverse events. And I have patients in my clinic with LDLs of 3 or 5. And if these are often patients with aggressive cardiovascular disease, and I'm comfortable with those numbers. Another drug, which is a PCSK9 blocker, but not an antibody. And how do you know it's not an antibody? Because the name will have SI, small interfering RNA. So inclisiran. Inclisiran is a small interfering RNA to PCSK9. So this prevents the translation of the protein. The benefit of this drug is instead of dosing it every 2 weeks, like you do with evinacumab and alirocumab, this is dosed only twice a year. So it's really a convenience thing for patients. They can come to your office for their visit, get their shot of inclisiran, or they can go to an infusion center and a nurse can give them a quick subcutaneous jab. It takes only a few seconds, and that way you don't have to worry about compliance. You do get a 50% reduction in LDL. This was approved by the FDA in late 2021 on the basis of these trials showing a reduction in LDL. The outcomes trial is still ongoing, and we expect to have results in a few years. So we'll watch out for this trial called Orion 4. Now, a word about TRLs, triglyceride-rich lipoproteins. Now, what are TRLs? Now, if you look at the cartoon at the bottom, you'll see that these are the different lipoproteins, and what they carry is a mixture of triglycerides and cholesterol, triglycerides in blue. And you see chylomicrons are mostly triglyceride particles, whereas LDL is mostly a cholesterol particle. But people forget that cholesterol is also carried by other particles, such as IDL and VLDL. And VLDL does not get a lot of attention. But the reason these other lipoproteins are important because they all have this apoprotein called apoprotein B100. And apoprotein B100 is what binds to the endothelium and takes this particle into the subendothelial space, where then it deposits its cargo of cholesterol. And so it doesn't matter whether the cholesterol that's penetrating your intima is coming from LDL or VLDL. In fact, some people think VLDL is more aggressive. As long as you have a particle that is capable of shuttling that cholesterol into the subintimal space, it will lead to atherosclerosis. So many people have advocated that instead of measuring LDL cholesterol only, a better marker of cholesterol burden and propensity for atherosclerosis is to measure this value, measure the ApoB100 value. And similarly, others have advocated that non-HDL, so anything but the HDL that carries cholesterol, is atherogenic. And both of those concepts are well borne out in clinical trials, and they are actually superior to just measuring LDL cholesterol. So why don't we do so? Because 15 years of guidelines has drummed that into patients. It's simple to measure LDL, although it's no more complex to measure non-HDL because it's a very simple calculation and you get it on the lab report. So many guidelines actually say, after looking at the LDL, look at the non-HDL, or look at the ApoB100. ApoB100 has to be measured. So that adds a little bit of complexity to it, but it does give you very good information on total atherogenic potential or risk. Triglyceride-rich lipoproteins, on the other hand, are all the cholesterol that's carried by everything outside of LDL or HDL. And these are important because most of the cholesterol in this comes from VLDL. And you'll see here that as the TRLs increase, and this is very common in diabetics and obese people and people with atherogenic dyslipidemia, VLDL cholesterol increases and HDL cholesterol decreases. And this has been strongly associated with cardiovascular events, and it promotes atherosclerosis and inflammation. So instead of just focusing on the LDL cholesterol, it would be good to focus on all of the atherogenic particles, including the one shown in green here, which is VLDL, typified by the triglyceride-rich lipoproteins. Or if you don't want to get into that sort of granularity, you can look at the non-HDL. And this is a good cartoon showing you the VLDL particle with an ApoB100 molecule, and the VLDL particle inhibits, because of its ApoC3 moiety, lipoprotein lipase, inhibits binding of the remnants to hepatocytes and intake by hepatocytes, and causes inflammation, increases cytokines and adhesion molecules. So all of these lipoproteins in part have significant atherogenicity. The most common particle that carries cholesterol in circulation is VLDL. So most patients, if you measure VLDL, you're fine. But for a substantial minority of patients, these additional measurements, such as VLDL, which is characterized, which is captured in the TRL measurement, can give you additional information. Now, we talked about triglyceride-lowering drugs. I mentioned that fenofibrate was a faceplant, despite 20 years of pushing that drug by the company. And unfortunately, most of the triglyceride-lowering drugs have not been useful to reduce cardiovascular events. This is just reported in the past 2 months with another drug called fenofibrate, which people had a lot of hope on. It did reduce triglycerides, but unfortunately, it also increased LDL because it increased ApoB. And so there was no improvement in cardiovascular outcomes. This was called a prominent trial. Other trials that have looked at either fenofibrate, niacin, or a combination of different kinds of fatty acids have again failed to show lowering of cardiovascular events. So it goes back to the dictum that just because a drug lowers a biomarker, we can't assume it's beneficial. We know that most drugs that lower LDL cholesterol do translate into cardiovascular outcomes, but for these other lipoproteins, we have to particularly study it. Now, fortunately, there was one silver lining to this triglyceride lowering story, and that was a drug called icosapent-ethyl. It's a very purified form of EPA, eicosapentaenoic acid. And this trial was called Reduce It, published in the New England Journal about 5 years ago now. Most patients had cardiovascular disease in this trial. A substantial percent had diabetes. Now remember that these were statin-treated patients, and their LDL at baseline was not bad, 75, so very near goal. Triglycerides were slightly elevated, not particularly catchy by any means, 216. And the intent of this drug was to see that whether lowering triglycerides translates into cardiovascular outcomes. Yes, the drug did lower triglycerides, but the benefit we saw in cardiovascular outcomes was phenomenal. It was a 25% reduction, including a reduction in all-cause mortality, and the number needed to treat was only 21. Furthermore, what was surprising is the benefit of the drug was not tied to the triglyceride lowering, i.e. patients who had less triglyceride lowering had the same amount of benefit as patients who had tremendous triglyceride lowering. So we think that the benefit of the drug is actually independent of the triglyceride lowering, which is a small component of it. It's likely from other things, such as antithrombotic and antiplatelet effects, anti-inflammatory effects, and plaque passivation. It's an antioxidant. So fatty acids, and not all fatty acids, specifically this fatty acid, has some beneficial effects on multiple biological pathways that translate into cardiovascular benefits. So even though it's a lipid-lowering agent, it actually does a lot more than just lipid lowering, and perhaps the lipid lowering is not why it's beneficial. So I'm not talking today about other drugs that are used in cardiovascular risk prevention, such as colchicine or the anti-inflammatory compounds that are in development, but because this is available, fish oil is safe, and it has such a dramatic effect in lowering cardiovascular mortality, I tend to prescribe it a lot to my diabetic patients and patients with cardiovascular disease because its benefits are outside of its lipid lowering effects. Now we'll shift gears and talk about another molecule that is you may have heard of, and anybody recognize this gentleman? He's Bob Harper, and he had an MI that obviously landed up on a ventilator at age 51. He is a very fit trainer on The Biggest Loser, and his only risk factor was this compound. It's a lipoprotein called lipoprotein little a. And sorry, this diagram is a little small, but what LP little a is an LDL particle that contains ApoB100, but then it is covalently bound to ApoA. And the reason this particle is so aggressive, it's an LDL-like particle, but it's worse. It's a super LDL because it causes inflammation because of oxidized phospholipids, and it causes thrombosis because it has homology to plasminogen activator inhibitor. Now, we found out that 20% of the US population has high levels of Lp(a). And many times when you see young patients who come into the myocardial infarction and no other risk factors, their Lp(a) levels are high, such that there's a log linear relationship between the level of Lp(a) or ApoA, it's apoprotein, and cardiovascular disease. And so this has really become a focus of another area of prevention now. Well, maybe it's not just all about the LDL, maybe it's about the LDL, the cholesterol contained in this other particle called Lp(a) also. And we should obviously focus on LDL reduction, but maybe we should focus on these other particles too. And because of that, now there are several compounds in trials, mentioning one here called pelacarsen, which is a subcutaneous injection given once a week. In a New England Journal trial, this lowered Lp(a) levels by 80%. So does that improve events? Well, that's a trial that's ongoing. I was part of this trial called Horizon, and we expect to see results of this next year. And aside from pelacarsen, which is an antisense oligonucleotide, there are a couple of other drugs which are also in the space. One is a small interfering RNA called olpasiran. The other one's made by Silent Therapeutics. And so you'll see patients who are getting tested for Lp(a), and if it's elevated, and elevated is defined as more than 125 nanomoles per liter, which translates roughly into 50 milligrams per deciliter, then those patients can be enrolled in these trials. I have a few patients that have sent for these trials, and we're really eager to see what their data looks like. I talked briefly about bempedoic acid being one step upstream of statins in lowering LDL cholesterol. This has the benefit of being a tablet, so it's a daily oral drug. It acts on the same pathway as statins do. It again upregulates LDL receptors, and in clinical trials, it reduces LDL by about 20%. So you can, there's a combination pill available with ezetimibe, so you can use bempedoic acid plus ezetimibe to get about a 40% reduction in LDL. And then if you add that on top of statin, you can reduce it more. It was initially designed for patients who have statin intolerance. Why? Because it's a prodrug. It requires activation by this isoenzyme, which is present in the liver, but it is absent in skeletal muscle. So the drug does not get activated in skeletal muscle, thereby avoiding myalgias and side effects. So we use it often for patients with myalgias, but it's also used as add-on therapy to statins. As I mentioned last month, the company announced that the outcomes trial was positive. So we're looking forward to the publication of data on this. I want to talk a little bit about the guidelines. We all know about the ASCVD risk calculator. Dr. Williams has always made it a fantastic teaching point that all of our residents have an EPIC, the calculation with this calculator. If you hit .ASCVD on your in your EPIC note, if those numbers are available, it will self-populate and give you the risk. This is quite useful in categorizing the 10-year risk. Remember that this is hard event risk, MI plus stroke. A low risk is less than 5%, high is more than 20%, borderline is 5 to 7.5%, and intermediate 7.5 to 20%. So, question that comes up all the time: should I get a fasting or a non-fasting lipid profile? Most times fasting is not necessary. Your patient's right there in front of you. If triglycerides are not a problem, not the focus of your question, if you're just focusing on LDL, you don't need a fasting. Now, if the patient's triglycerides are known to be more than 400, or you're trying to assess the triglycerides particularly, then you should have the patient fast. That's the only time I would bring them back. But for the majority of patients, they're right there. It's convenient. You can do a cholesterol finger stick, or you can send them to the lab right away. If you're looking just for the LDL and not particularly concerned about the triglyceride value, historically, you know that they don't have diabetic dyslipidemia, et cetera, then you don't need to have them fast. For very low LDLs, our lab will give you erroneous numbers. There's a big splay between correct LDLs, especially on the very high or very low extremes. So in that case, you can order a direct LDL. So my order is often lipid profile with reflex to a direct LDL. That's an option available. Or you can use the Martin Hopkins formula. For those of you interested, there's an app available on this, and this uses a different formula rather than the free-to-vault formula for calculation. So the LDL value you get for this from this is more reliable. Talk about the guidelines a little bit. I won't have too much time to spend on this because this has already been covered in a prior talk, and most of you know these. But in essence, the guidelines ask you to focus on assessing risk via the calculator, and then having a risk discussion benefit in treating the patients. If the risk is intermediate or high, you want to treat them. Less than 5%, you can defer treatment, and borderline risk, you can use your risk enhancers to see if they have any of these features. Then it pushes you to try to prescribe statins for your patients. And the 4 statin benefit classes are patients who have LDL of more than 190. These are primary hypercholesterolemia or diabetics, or folks who, after this risk calculation, fall in the intermediate or high risk group. So for those of you interested, I wanted to cover mostly new advances rather than old data. This is data from 2018. I'm sure most of you are familiar with these, but for the residents, if you need these slides, I'm happy to share them with you. I'll pass them on to Jason after the talk, and you're welcome to look at this in greater detail. Coronary calcium scoring is really, in my practice, revolutionized how we risk refine people, because the addition of calcium information benefits your decision-making process. We know that calcium in the coronaries, this is a non-contrast CT, does not require IV, does not require any drugs. More the amount of calcium, the worse the cardiovascular prognosis. But the reverse is also true. Our risk calculators are based on testing hundreds of thousands of patients, but they're not personalized. Whereas when you get a coronary calcium score, it's that person's atherosclerotic burden, because calcium is pathognomonic for atheroma. And if you look here in this important trial done by Khurram Nasir, when the calculator recommended that you give a patient a statin, about 40% of them had a calcium score of 0. So these people would not have benefited. So sometimes you get these patients who are 75, and just because of their age, they're deserving of a statin because their pooled cohort equation calculator puts them at higher risk. But you can use these sort of tools such as risk enhancers or the coronary calcium scan to either increase their risk or to de-risk them and decrease their risk. In that case, you can hold off on a statin if their calcium score is 0. Secondary prevention, I won't spend too much time on. All of you know that you've got to start with a high intensity statin, get their LDL below 55. These are the new guidelines. You want to get it at least below 70, but preferably below 55, especially if they're more than one risk factor. The Europeans are even more aggressive, saying get it less than 55 or even less than 40 if they've had an ACS in the past 2 years. And we in India have written the Lipid Association of India guidelines, and we think that diabetics with coronary cardiovascular disease, South Asian population is particularly high in risk, and so we want the LDL goal to be less than 30. I'll do a quick case. If you have time, I'll do some other more interesting cases, but I don't think we'll have enough time, so I'll stop after this case. So 51-year-old man, his father had an MI at age 52. He's a non-smoker. BMI is 32, waist is 41 inches, blood pressure is okay. His fasting blood sugar is 102, A1C of 5.6, and he asks you, what would you do? So I give you a lipid profile, and his LDL is 101, so that doesn't alarm you. His HDL is low, and so you pull out your risk calculator, or you do it in Epic, and you plug in all these numbers, and you get his risk score of 3.6%. Now remember that this is considered low risk because it's under 5%. So the questions really are statin or no statin, aspirin or no aspirin. They said, wait a second, Dr. Kalra just told me all about these other risk enhancers and calcium scoring. Let's do a calcium score on it because he wants to really know what's going on. So his calcium score actually shows a spot of calcium in the LED. So his calcium score is 25 Agatston units. And his CRP, which is another risk enhancer, is 2.4, which is elevated. His Lp(a) is fine. His ApoB is also normal. So you use the MESA calculator, which incorporates the calcium score. You put in the value of calcium score of 25, and this is again available online. And now you get a risk of 5.9%. So you've gone up from 3.6% to 5.9%. So he's in the intermediate risk category. And he has 3 risk enhancers. He's got a family history, he's got metabolic syndrome, and he's got a high hsCRP. And now this really pushes you to consider this patient for a statin. He agrees, so he obviously starts to exercise and lose weight. You put him on a plant-based diet, and you put him on a atorvastatin. There's no need for aspirin yet because his calcium score is less than 100. You don't really get a benefit about that value. So I had a lot more slides. I'm going to skip some of these to go to the very end. Do want to talk about the future. So what does the future hold? So the future holds 2 things. One is we're getting better at risk prediction, as I showed you with calcium scoring, but we're also getting better with something else, with polygenic risk scores. I've talked a lot about single nucleotide polymorphisms. Now we know when people have monogenic disorders, such as when you LDL receptor is knocked out and you have familial hypercholesterolemia, you have very high risk of cardiovascular disease, 4-fold higher risk of MI at least. But this occurs in only 0.4% of the population. This is a paper in Nature Genetics from a few years ago, where the group from Mass General looked at about 6,000 single nucleotide polymorphisms in the UK Biobank of about 300,000 patients. And they came up with a score using all of these polymorphisms that was tied into the risk of future cardiovascular disease. And they validated it in the sense that this abnormal score was present in 5% of the population. But when patients were coming in with a myocardial infarction to the CCU and they were young, had no other risk factors, and you ran the polygenic risk score, 17% of those patients had an abnormal polygenic risk score. And the odds ratio for myocardial infarction was as high as if you had familial hypercholesterolemia, a monogenic disorder. So the meaning of all this is if you could use polygenic risk scores, that allows you the opportunity very early on, even as a child or even right after being born, to do this genetic test. Say your polygenic risk score is abnormal, your lifetime risk of developing cardiovascular disease is high, so we're going to be more aggressive for you and treat you early on rather than wait until you're 40 or 50. So this is an evolving area of risk prediction right from birth. Lastly, treatments. We obviously talked about high potency statins, which you have to take every day, monoclonal antibodies, which you have to inject yourself. So that's 26 injections a year. Talked about inclisiran, 2 injections a month. Now there's vaccines in development that can knock out PCSK9. So you may only need to get 1 or 2 vaccine shots in your lifetime, or gene editing. So CRISPR has now come into the clinical realm. There's a company, several companies actually, that are injecting an intravenous compound that uses the CRISPR mechanism to turn off the PCSK9 gene. And by doing so, you reduce PCSK9 in the blood, as well as LDL reduction. This has been tested in primates, very promising data, 61% reduction in LDL just with 1 CRISPR injection. And so if you can do that in humans and reduce your LDL for life after that, that would be phenomenal. And so the clinical trial has just started in patients. We really want to see the data on this. And one of the most famous cardiologists who is still living, has written the textbook of cardiology, Braunwald, has given an opinion on how to live 100 years before developing coronary disease. And his proposal is to get the LDL as low as possible for as long as possible. And so keep calm and lower your LDL. I'll stop there and happy to take questions.
Thank you so much, Dr. Kalra. That was amazing. And Jason, I know you're collecting the questions, but I'll take the chair's prerogative and start. I have three big questions, but we probably only have time for one, so we have to choose between them. I think one of the biggest controversies that I'd love to hear your opinion on is you talked about giving a lot of patients based on the strength, no pun intended, of the DHA removal and using EPA. And the problem with that trial, Reduce It, is that it's being largely criticized by the strength investigators who came up with a very negative trial, saying that they set themselves up for success by using mineral oil instead of corn oil as a placebo. And so there's this whole, and it seems to be divided in two camps: the people who believe that Reduce It is okay, and the people who say that it's complete, a wash because they used the wrong placebo. What's your take on that?
Yeah, so my take on that is, while it's true that mineral oil did increase LDL, the amount of increase in LDL was not sufficient to see all the benefits that we got from EPA. So for those of you who are not aware of this controversy, when the people who designed Reduce It gave the EPA formulation in the placebo arm, they used mineral oil. And the criticism is that mineral oil increases the LDL by a little bit, by about 2 to 3 milligrams per deciliter. But the benefit that we saw with EPA was 20-25% mortality reduction. And that would not have been achieved with just the adverse increase in LDL-C in the placebo arm. So that's one. And the FDA has carried out an extensive analysis on this. And they found the same results, that the increase in LDL, while true, was not sufficient, way short of the increase in cardiovascular events you would have gotten in the placebo arm just by 2 or 3 milligrams per deciliter increase in LDL in the placebo arm. Number two, CT data, as you know, with Matt Budoff's group from Evaporate, has shown that using EPA decreases the amount of lipid-rich plaque. So there's a mechanistic basis for why EPA is working by plaque reduction. And lastly, the reason strength failed. Strength was a combination of EPA and DHA, and EPA dose was not enough. So whenever we use low doses of fish oil, they don't work. And we've seen that in other trials called Vital and Ascend. You have to use 4 grams per day of EPA in the American population. And the Japanese, you can use a little less because they have a lot of fish intake normally. But if you don't, in strength, when they use only about roughly 2 grams of EPA, the serum levels of EPA were not high enough for benefit. Whereas if you look at Reduce It, the serum levels are 4 times as high. So the benefit is all tied into the serum levels of EPA. EPA somehow is a magic molecule that stabilizes membranes, reduces plaque burden, reduces inflammation, reduces oxidation. That's how it works.
Fantastic. Dr. McLean, see your hand up.
Yeah, so on that particular issue, linoleic acid is actually highly pro-inflammatory, so it probably wouldn't be a good, quote, placebo because it's bad. And if you look at the EPA and DHA, they're metabolized to things called resolvins that are highly anti-inflammatory and are one of the hottest things in medicine right now. And if you give a little aspirin, you stimulate that process to make more resolvins. So potentially if you gave aspirin and your EPA and DHA together, you get even a bigger effect.
Yeah, fantastic. You're absolutely right. And most of the patients in REDUCE-IT were secondary prevention patients, about 70% of them. So a lot of them were on aspirin, but you're absolutely spot on. The anti-inflammatory effects of EPA are just beginning to be discovered. How it stabilizes the phospholipid bilayer, how it reduces inflammation, and the combination with other anti-inflammatory agents, including aspirin, potentiates that benefit.
So it looks like Dr. Levinson has his hand up,
Hold on.
but you're on mute. Is that right?
Let me hold on a second. Let me see. And
Are you able to unmute him?
let me.
Came up. Sorry. Okay. We okay? Can you hear me?
There we go.
Yeah.
Yes.
Yeah. When we talk about the particular EPA drug we're talking about, it's a very expensive drug. Now, my thought has been that if the LDL is biased in the control group, then that's going to push the number needed to treat even higher. So even though there may be an effect, we may be talking about, and I don't know how much, number needed to treat is say 50 with a very expensive drug. So then you have to look at the economic and some clinical value with that.
Yeah, I mean, you bring up a great point. I think so. Number needed to treat is a great number, but cost is all relative. So this company, Amarin, when they designed the trial, prior to that, they were about to lose their patent. And in fact, it was not as expensive. And sometimes as happens is after a drug becomes a blockbuster, the price goes up. Nonetheless, for patients who have commercial insurance, I can typically get it to them for $10 a month. It's basically purified fish oil. So in terms of expense ratios, it is still about 50-fold less expensive than the injectables like PCSK9s, which are about $5,000 a year, or gene therapy, which is going to be probably millions of dollars a year. So it's all relative, but your point's well taken. You know, in the right patient, statins are obviously pennies. In the right patient, diabetics, atherogenic dyslipidemia, or cardiovascular disease, what is the cost you want to pay for a 20% mortality and MI reduction? I think, $10 a month is probably okay for the patients who have the copay covered.
Well, thank you, Dr. Kalra. I think we have to be responsible and let people get back to work. I would love to spend more time talking to you about vegan diet, caprostanol conversion in the GI tract by changing your microbiome. Love to talk about how, you have the statins and the PCSK9s, and statins actually increase LP(a), but they seem to reduce events percentage-wise, comparing IMPROVE-IT versus Odyssey and Fourier a little bit better, actually, than what happens with the LDL reduction of PCSK9 inhibitors. But we'll have to, like myself and everyone else, I encourage you to find Dr. Kalra and get all of the expert answers to these types of complex questions. But you showed that this is a spectacular field that actually is going to have even increasing impact on cardiovascular medicine. So thank you so much for this wide-ranging discussion and an incredible amount of education today.
Thank you.
All right, and thanks everyone. And Dr. Kalra, if you can hang out for just a couple more minutes, we're going to record the Cardinal Minute in just a minute. We'll be back next week, and our friends from GI will be hosting, and we have a special guest who'll be speaking, Dr. Ashwani Singhal from the University of South Dakota. And he is the editor-in-chief of Translational Gastroenterology Hepatology, and amongst other things. So we'll look forward to that. That'll be next Thursday. So that will be January 12th at 8 a.m. So we look forward to seeing everybody back again. And thank you, Dr. Kalra, and thank you, Dr. Williams. And thanks, everyone. We'll see you next week.